Hello everyone, welcome to this video in which I'll be discussing the Dermatology Recall questions asked in the FMGE exam conducted this year on the August 31st. Yes, this exam was quite difficult, and if I just talk about the skin questions, I'll say that asking 13 questions is totally different from the 5-6 questions that were asked in all these over the last 5 years. 13 questions from dermatology is way too much. Plus, newer images, newer questions. So, what they're doing is asking us to take our game a notch higher. Let us start with the first question here. Which organism is responsible for causing erysipelas? Streptococcus pyogenes, Staph aureus, Bacteroides fragilis, and Trichophyton rubrum. First of all, rule out the least probable. Erysipelas we know is a bacterial infection of the skin. So option D can never be the answer. Trichophyton rubrum is a fungus. That is gone. To choose between A, B and C, let me tell you a brief overview of Erysipelas. So this is a bacterial infection caused by which the answer to that is the Streptococcus pyogenes. The level of involvement is very important in the pyodermas. Impetigo involves the epidermis, ecthyma, dermis, erysipelas, the dermal lymphatics. A very important question from erysipelas is the involvement, that is the dermal lymphatics. Clinically, it looks like a well-defined, very important word which I used here, well-defined, erythematous plaque. That is also something that you can see in the image here. Look at the image. See the margin of the lesion. Do you see that this is such a well-defined red lesion? It has a clear demarcation between the involved and the uninvolved skin. This is the involved and the uninvolved. You can clearly make out the difference. So these are some important clinical features which are also used to differentiate erysipelas from cellulitis. Cellulitis is also a bacterial infection which mainly involves the subcutaneous fat, but it is a loose swelling which doesn't have any clear margins. So that is an important criteria to differentiate cellulitis from erysipelas. Points to notice: caused by Streptococcus pyogenes, involves dermal lymphatics, and it has a clear demarcation between the involved and the uninvolved skin. Coming back to the question, which is the organism responsible for causing erysipelas? Tell me, the answer to this is option A, that is the Streptococcus pyogenes. Now, when we talk about the bacteria here, a lot of questions come from this part every year. Which are the infections caused by Streptococcus and Staphylococcus? So this is a list here. Strep causes non-bullous impetigo, ecthyma, erysipelas, cellulitis, necrotizing fasciitis, and scarlet fever. The questions mainly come from these three options. Another question from scarlet fever is that it shows the presence of strawberry tongue. Strawberry tongue is also seen in Kawasaki fever. Okay, so these are the infections caused by Streptococcus, and the ones caused by Staphylococcus include mainly the bullous impetigo, ecthyma, and all these follicular pyodermas. So skin, it will infect the hair follicle, and it will also infect the nails, causing acute paronychia. So see, it is causing infection of skin, hair follicle, and the nail fold. So these are all the infections which are caused by Staph aureus. The toxin leads to two more disorders, which is staphylococcal scalded skin syndrome and the toxic shock syndrome. Very important is the staphylococcal scalded skin syndrome. Okay, so this list should be clear to all of you. Coming to question number 2, the most favorite topic. Pick up any question of the last 10 papers, any paper, you will find a question on this. But this time, it's a slightly different question. Okay, every time they will just ask you the image or they will ask you the cause. This paper, they are asking you the complication. So what is a common complication associated with the condition shown in the image? So let us see what is the image telling us. Image is telling us that the lesion is present on the perioral area. So this is a lesion which is present in the perioral area. And how does it look like? It is probably an erosion. I cannot make out because it is covered with a very beautiful golden yellow honey colored crust. So the image here is telling me that there is a lesion which has a golden yellow honey colored crust. What is that? That is nothing but our very own non-bullous impetigo. Non-bullous impetigo caused by whom? Caused by the Streptococcus pyogenes. And what will be a complication associated with this? A complication associated with that would be post-streptococcal glomerulonephritis. Okay, so that makes our answer pretty simple. An image which shows us a golden yellow honey colored crust taking us to a diagnosis of NBI, which we know is caused by Streptococcus, a complication of which is PSGN. S4 is caused due to Staph aureus. Encephalitis, generally not caused by Streptococcus, as a complication of skin infection. Pneumonitis, not caused due to skin infections. So this is not the answer, neither this nor this. The answer to question number 2 is the option A. A few details about impetigo. This is a superficial bacterial infection of the skin because it involves only the epidermis. It is of two types, non-bullous and bullous. Non-bullous is the most common type of impetigo. Then it is also the most common bacterial skin infection seen in the children. Clear? These 2 points. Talking about non-bullous impetigo, it is caused mostly by Streptococcus, seen in children, most commonly on the face in the perioral region, and clinical feature I just told you, a beautiful golden yellow crust. A complication, PSGN. So very important to know the honey colored crust that happens in the non-bullous impetigo. Bullous impetigo is caused by Staph aureus. So this is a distinction that all of you should remember. This is caused by the Staph aureus. Clinically, it will look like a bulla which is full of turbid fluid. It is actually pus. What is the reason for bulla? It's a toxin which is secreted by the bacteria, which is called as epidermolytic toxin, also called as exfoliatin. Targets desmoglein 1. So when a toxin is targeting desmoglein 1, it will cause acantholysis, leading to formation of a subcorneal bulla. Okay, very important, these questions. Caused by Staph aureus, the name of the toxin which is exfoliated, target of which is desmoglein 1, and the level of bulla formation is the subcorneal bulla. Coming to question number 3. A child presents with sores in the mouth, rash on the hands and feet as shown in the image. What is the causative organism? So what is the question telling us? Question is telling us that there is an involvement of the mouth plus hands plus feet. So these are the 3 things involved. Coming to the image. Again, what you see is some tiny vesicles and aphthae in the oral cavity, a rash on the hands, a rash on the feet. I don't even need to remember the name of the disease. the disease itself is visible in this picture. It is called as the hand, foot and mouth disease. Caused by which virus? Tell me. I'll tell you. Don't worry. So, what is HFMD? This is hand, foot, mouth disease, mainly caused by the Coxsackie A16 virus. There are some other viruses, but we'll focus on the most common and the most important question, that is Coxsackie A16. Clinical features, just what is mentioned in the question. You get a vesicular rash on the oral cavity, on the hands and the feet, as you can see in the image here. This is a self-limiting disorder, don't require any treatment. So this is the HFMD. Coming back to the question, yes, we have Coxsackie A16 in the option. So the answer to question number 3 is the option A, that is Coxsackie A16. Remember the subtype A16. There are other subtypes like A1 to A10. They cause another disease which is called as herpingina. Okay, so in this option, had you had some other subtype like this, that would not have been the answer. The answer is A16. Clear to you? Okay, A16. What are the other options? Pox virus. Pox virus causes molluscum contagiosum. So, herpes virus causes herpes labialis or genital herpes. And HPV, human papilloma virus, causes warts. Answer A. Then we come to question number 4. A child presents with an ulcer with undermined edges in the neck, as shown in the image below. What is the diagnosis? Well, if I had a question just with this text, even without the image, the answer is very straightforward. It is giving us a hint, which is ulcer with undermined edges in the neck. When we talk about undermined edges, I'm just giving you an additional point here. Even though if you look at the image, it's a very simple question. But when we talk about undermined edges in dermatology for you are seen only in 3 disorders. 1, Scruffalo Derma. 2, chancroid. 3, pyoderma gangrenosum. So these are the 3 ulcers which will give you undermined edges. Scruffalo Derma, chancroid and pyoderma gangrenosum. One question which is otherwise asked in the exam is rodent ulcer. That's a type of BCC. So they don't generally ask you the differential of this as an undermined edges, but still remember. Okay, so Scruffalo Derma, chancroid, pyoderma gangrenosum and rodent ulcer type of BCC. Scruffalo Derma will generally present on the neck. Chancroid is an STD, so it will be present in the genitalia. Pyoderma gangrenosum, mostly the images are that of the leg, and BCC will be on the face. Okay, so the site is also different for all these ulcers. Now coming back to our question, ulcer with undermined edge on the neck, out of these it is Scruffalo Derma. Now look at the image here. In the image you notice another thing, which is a bluish or a violaceous margin of the ulcer. So this bluish margin is again very typical of tubercular ulcers. Okay, so this is again very typical of tubercular ulcers. In our options, what are they given? Tubercular lymph node, definitely, it means Scruffalo Derma here. Malignant cervical lymphadenopathy will not present with undermined edges. Syphilis will not present like this, and reactive lymphadenopathy will not rupture on the skin. So these 3 options are as it is ruled out, making option A, that is tubercular lymph node or Scruffalo Derma, as our answer here. See, I didn't even need to look at the image. Just the text was sufficient to let me make the diagnosis. In most of the questions, I'm telling you that The hints given in the text are very important. Capture them. Just don't get scared of the image. Oh, I'm not able to understand the image. No. Read the text. Try and understand what they are asking you. Look at the options and then you see the image. That makes it easier to interpret the image. Okay, so in the neck, it makes it Scruffalo Derma. On the genitalia, chancroid. On the leg, Pyoderma gangrenosum. So these three important differentials of undermined edges in an ulcer. Showing you another image of Scruffalo Derma. Scruffalo Derma is a cutaneous tuberculosis which is the most common type of cutaneous TB in children in India. Okay, so this is the most common type of cutaneous TB in children. Happens due to direct contiguous spread of infection from the internal source onto the skin, which ruptures in the form of an ulcer with typical undermined edges and bluish margins. There is copious amount of pus which is full of AFB. The most common internal source are the cervical lymph nodes, and the most common site obviously will be the neck. So these are further two questions that come from Scruffalo Derma. Which is the most common type of cutaneous TB in adults? In adults, it is lupus vulgaris. Okay, in children, Scruffalo Derma. In adults, lupus vulgaris. Coming to question number 5. A child presents with fever, Cleomorphic rash as shown in the image. What is the diagnosis? Now, again this hint. Now you will say, ma'am, what does pleomorphic rash mean? See, if you just look at your fever with rashes, then pleomorphic rash happens in just one. Pleomorphic means polymorphous. Polymorphous is classical of varicella. Classical of varicella. What does that mean? See, this image is also telling us there is a vesicle, there is a ulcer, papule, scab. So multiple stages of the disease seen at the same time in a patient, making it a pleomorphic rash. When you see that with fever, the answer is nothing but varicella, which is another name for chickenpox, making option A our answer here. That is, fever with pleomorphic rash is equal to chickenpox. Caused by which virus? Also called as VZV, which is the Varicella Zoster virus. Clinical features: we just saw fever with pleomorphic rash. The rash over here has a sign which is called as dewdrop on a rose petal. So this rash has two features. One is the pleomorphic and two, dewdrop on the rose petal. That's classic of varicella, also called as chicken pox. When this virus lies latent in the body, it can get reactivated at times when you have poor immunity. When it gets reactivated, leads to a disease called as herpes zoster, also known as shingles. So you get a question on shingles. Where does the virus lie latent? In the dorsal root ganglion. Most common site of eruption, thoracic area. Presents as multiple grouped painful vesicles. So multiple grouped painful vesicles on a red base. What is the distribution? Very beautiful. You can see in the image also. Presents along the dermatomes. So this eruption happens along the dermatomes. If you make a Zank smear, it shows MNGs. Who will tell me the full form of MNGs? These are multinucleate giant cells. Treatment of choice, acyclovir. What is post-herpetic neuralgia? That is persistence of pain of zoster for more than 1 month after the disease has subsided. Okay, So this definition is asked, drug of choice, sac finding, the distribution, the most common site, and the latency. All these are important questions. Let us revise again. Synonym is shingles. Dorsal root ganglion is the site where it lies latent, erupts commonly in the thoracic area. Treatment of choice, acyclovir. Post-herpetic neuralgia is pain lasting more than 1 month. If you get this as an image-based question, just look at these multiple grouped vesicles which are lying linearly along a dermatome. Nothing else in entire dermatology looks like this. Okay, so if you get any such image, if it is on the face in the ophthalmic area, it is Herpes Zoster ophthalmicus. If there are vesicles in the external auditory canal, it is Herpes Zoster oticus, which is the Ramsay-Hunt syndrome, or on the body, anywhere these linear vesicles. Coming to question number 6. Identify the condition shown in the image. So what is the condition shown in the image? Well, this is a question which is not giving you any hint in the text. So you have to do the entire interpretation from the image. Let us see what the image is telling us. The area is perianal. See, whenever you have perianal or genital lesions, think of an STD. Okay? Perianal genital, first think of a STD. What do you see? You see multiple grouped lesions here. Group lesions which are papules and which have a rough verrucous surface. Now, go back to the STDs that you've read. Grouped papules with a rough verrucous surface either on the penis or the vulva or the perianal area. What is the answer? To answer that, you have to know these are warts. Warts caused by the human papilloma virus. Now in my options, do I have warts written? No, I don't have warts written. Then what is my answer? The answer is option A. That is condyloma acuminata. Condyloma acuminata is another name for warts which are caused by HPV. Bowen's disease is a different thing. That's almost like an SCC in situ. It's a dysplastic change which is caused due to this virus, but that doesn't look like this. Condyloma lata is seen in secondary syphilis. Again, it does not look like this. Hemorrhoids are due to venous dilatation. Again, it does not look like this. So, rough verrucous papules in the perianal region. Answer is condyloma acuminata, which is another name for viral warts. These are all the images that they ask you here, either of the penis or of the perianal area. Everywhere, just look for these warts which have a rough surface. And if you notice on these warts, they also have a pointed tip, and it is the presence of this pointed tip which gives it another name, that is condyloma acuminata. Caused by HPV 6, 11, 16, 18. Most common is HPV 6. So most common cause is HPV 6. How do you treat? The question that they ask you, which is the immunomodulator which you use in the treatment of genital warts. The immunomodulator used here is imiquimod. Then, what is the treatment of choice in pregnancy? That is cryotherapy. If cryotherapy is not in the option, the next answer is the use of trichloroacetic acid. So these are the important questions that come from the genital wart. Just remember the synonym condyloma acuminata. Question number 7. Auspit sign. A very favorite question, very often asked question. So I'm sure all of you got it right. The answer to that is, oh no, I am the one who's getting it wrong. No, I just marked it wrong. So Auspit sign is seen in, this is seen in psoriasis vulgaris. Well, that's an easy question. You all will agree. What is psoriasis? Psoriasis is a autoimmune disease? What is the gene? HLA-CW6. Seen bilaterally symmetrical on the extensors as well defined erythematous plaques with silvery white scaling. There is a ring sometimes around the lesion, that is a pale area, also called as the Bornoff's ring. Okay, so what are the HLA associated? CW6 has a classic silvery white scaling, and there is an area of pallor around the lesion which is called as the Bornoff ring. What are the clinical signs? The first test that you can do is called as the retarge test. In retarge test, you scratch a psoriatic lesion with a glass slide. When you scratch the psoriatic lesion with a glass slide, you see a pinpoint red bleeding in the center of the lesion. This pinpoint bleeding which you see on scratching the lesion is called as the Auspitz sign. Very, very important question. Here they ask you Auspitz sign. They can even ask you this as an image. So when you see this image, first of all, look that the lesion is a red scaly plaque. So first thing that you see in the image is that it is a lesion which is red, which has silvery white scaling. In the center of the lesion, it has been scratched, and where it has been scratched, I can see some pinpoint red dots, which in itself means this is pinpoint bleeding, taking me to the answer of Auspitz sign. So either way, text or image, you should be able to identify this picture. Look at it again, a red scaly plaque with pinpoint bleeding in the center. Another sign which is a very often asked question from psoriasis, that is the Cobnus phenomenon, also called as the isomorphic phenomenon. As the name suggests, isomorphic means similar looking lesions erupt at the sites of trauma or scratching in a patient. So when they are happening along a scratch, they will be linear. In any image, you see these linear lesions, think of Cobnus. Okay, so imagine me scratching. So when I scratch, new psoriatic lesions appear along the scratch. They will be linear. Think of Cobnus phenomena, also called as the isomorphic phenomena. It's of two types, true Cobnus and the pseudo Cobnus. True Cobnus is seen in 3 disorders. First, we've just studied psoriasis. Then we have lichen planus and we have vitiligo. So 3 disorders where you see true Cobnus: psoriasis, lichen planus and vitiligo. What about pseudocobnus? Seen in 2 viral diseases, that are warts and molluscum contagiosum. Okay, very, very important questions are the causes of these true and pseudocobnus. True is seen in 3 disorders: psoriasis, lichen planus, vitiligo. Pseudocobnus seen in 2 viral infections of the skin, warts and molluscum contagiosum. If you get it as an image-based question, I just said look for these linear lesions. When you see such linear lesions, think of Cobnus. Coming to question number 8. What is the first line treatment for acne comedons? Well, that's a new question. Every time they've been asking you treatment for nodulocystic acne, this time they have asked you treatment for comedonal acne. So comedonal acne, I'll just tell you. Look at the image here. This is comedonal acne. Comedons are the primary lesions of acne. Acne is a disorder of the pilosebaceous unit. That's very important. Sometimes in the option they will give you hair sebaceous gland and pilosebaceous unit. So the answer is pilosebaceous unit because both hair and the sebaceous glands are involved in acne vulgaris. Coming back to the lesion, comedones are the primary lesions, but in the most severe acne, what do you see? You see nodulocystic lesions, which is also called as nodulocystic acne. This is the most severe type of acne. It can be asked as an image-based question. When you see this as an image-based question, see these big nodulocystic lesions. These are that you see in a very severe patient of acne. When we talk about the treatment of acne, we divide it into 4 stages. The first stage, that is comedone, then papule, pustule, and the nodulocystic phase. And the treatment is also decided by the severity of the disease. In grade 1, which is the comedonal acne, the treatment of choice is topical retinoid. The topical retinoids that can be used include tretinoin and adapalene. So if my option did not mention topical retinoid, my answer could have been a drug like tretinoin and adapalene, but thankfully my question is telling me this option. So the answer to question number 8, that is first line treatment for acne comedones, the answer is D, topical retinoids. Coming back to the next grade, which is grade 2, where you have papules, you will add a topical antibiotic to topical retinoid. The antibiotics that we use here include topical clindamycin, topical azithro, nadifloxacin, even topical dapsone. In grade 3, where the patient is developing pustules, you add an oral antibiotic to the topical retinoid. The oral antibiotics that we use here include tetracyclines like doxycycline, minocycline, macrolides like azithromycin, clarithromycin. The question that you get here is on side effect of minocycline, which is pigmentation. So a drug which is used for treatment of acne that can have pigmentation as a side effect. The answer to that is minocycline. And the most important and the most frequently asked question is the treatment for grade 4, which is the nodulocystic acne. The answer to that is oral retinoid. The retinoid that is used here is isotretinoin, used at a dose of 1 mg per kg per day. Total cumulative dose used is 120 to 150 mg per kg. The most common side effect for this is cheilitis, which is dry chapped lips, but most important side effect, yes, tell me, it is teratogenicity. So the prerequisite for starting isotretinoin in a woman of reproductive age is the negative UPT. You always do a negative UPT before you start isotretinoin. And the patient is supposed to use a double contraceptive while they are taking this drug. Coming to question number 9. Which mineral deficiency can lead to the following condition? Again, here the text is not giving us any hint. It is only telling us that there is a mineral deficiency. Now, what is the image saying? Image is saying that the patient is a baby. So that is the first thing that I make out in the image. It's an image of a baby. The lesions are on the face in the perioral area. Now, what are these lesions? These are erosive lesions. These are all red raw erosions. So what I get from the image is that there is a baby who has erosive lesions in the perioral area of the face. Which deficiency can lead to this? Everyone knows this answer. The answer to this is this. Presence of erosive lesions in the perioral area and the groin. The answer to that is Acrodermatitis enteropetica. Okay, very important image-based questions. Both perioral as well as the perineal area can be involved. Deficiency, tell me. zinc. Inheritance, autosomal, recessive. Apart from the erosive lesions, we also remember the clinical features as a triad, DAD, D-A-D, which is D for diarrhea, A for alopecia, and D for dermatitis. So remember the triad of acrodermatitis enteropathica as diarrhea, alopecia, and dermatitis. Very important image-based questions because there are these erosive lesions which are present in the periorificial areas. The periorifices mean around the openings. Openings could be the mouth and the anal cavity. So what is the answer to this question? This image is representing acrodermatitis enteropathica, which is deficiency of option A, that is zinc. What about option B? Iron causes koilonychia. So deficiency of iron causes anemia, which presents as koilonychia. Niacin, which is vitamin B3, the deficiency causes Pelagra. And vitamin A deficiency causes 1. Night blindness. In the skin, it causes Derma, which is frog-like skin. Okay, so these are all the important deficiencies. I have also put an image of Pelagra because that is also a very often asked question. So this image has been asked multiple times. Even in the December 2019 exam, it was there. It happens, we just discussed, due to deficiency of vitamin B3, which is also called as niacin, presents as a triad D, D, and D. So what are the 3 Ds here? Starts with diarrhea, then dermatitis, ultimately leading to dementia, and if untreated, a 4th D is added, which is death. When we talk about the dermatitis, the rash is photosensitive, so it will happen in photo-exposed areas. On the neck, it presents as a very beautiful Cazel's necklace, which is a very, very important question, both as text as well as image. So remember Cazel's necklace, which is presence of this photosensitive rash on the neck of a patient, that is Pelagra. Coming to question number 10. A cutaneous horn, as shown in the image, is associated with which of the following skin cancers? So cutaneous horn was a new question, not asked before, stumped a lot of students, but many of them also guessed it right. So cutaneous horn image, actually I've put here. So this is the image. This is a horn that you see coming out of the skin like this. So this is a cutaneous horn. On the base of this horn, you mostly have a skin cancer which is developing. The answer to which is option A, squamous cell carcinoma. So the cutaneous horn, as shown in the image which I just showed you, is associated with squamous cell carcinoma. Very, very, very important to remember other associations of SCC, which includes actinic keratosis, arsenical keratosis, keratoacanthoma, Bowen's disease, and now cutaneous horn, as well as a burn scar. Burn scar leads to a type of SCC, which is also called as marginal ulcer, which is a very, very, very often asked image-based question for you in the exam asked in the June as well as the December 2019 exams. So coming back to associations of SCC, actinic keratosis, arsenical keratosis, keratoacanthoma, Bowen's, cutaneous horn, and marginal ulcer. See, this is an image of the cutaneous horn. This is like a horny structure which is made of keratin. At the base of the lesion here, you have almost an SCC developing. So this is associated with the answer squamous cell carcinoma. Coming to question number 11, identify the condition shown in the image. Okay, so what does the image show us? See, the lesion is present on the face of this patient, which is a sun exposed area. And if you look at the photo of the patient, this seems to be an old person. So an old person with a lesion on the face, it is a pigmented lesion. This has a irregular boundary. So this lesion has an irregular margin. Then somewhere it is light brown, other areas it is dark brown, which means it has variable colors. The border is also uneven. So this is what I can make out from the image of the lesion. Now let us look at the options. Nevus. A nevus will never present like this. Nevus will always be a well-defined lesion with clear margins. So this is not how a nevus will look. SCC will be maybe a verrucous lesion, it will be a rough body lesion, or it will be an ulcer, but it will not look like a pigmented lesion. BCC will be skin colored with rolled up borders. Again, it doesn't have to be a flat lesion like this. The only answer which matches the image here is option A, that is the malignant melanoma. How do you identify malignant melanoma? See the ABCDE of the lesion. The A means asymmetry, which was there in our lesion. Uneven borders, again we saw that. Multiple colors, diameter more than 1/4 inch, which is 6 millimeter. Our lesion was quite large, and the history will tell you that it is evolving. That means there are some changes which are happening in the lesion. So when you look at a pigmented lesion, do its ABCDE. Asymmetry, border, color, diameter, and evolution. When you come back to the image here, all these points favor our diagnosis of a malignant melanoma, which make option A as our answer here. Now, some more points about malignant melanoma. This is a tumor of the melanocytes. Generally happens in the sun-exposed areas. The most common type of malignant melanoma is superficial spreading. The most common type is the superficial spreading. This is world over. But in India, most common type in India is what I've shown in the image here. That is the acral lentiginous melanoma. So the most common type seen in India is the acral lentiginous melanoma. Acral means on the acral areas, so on the hands and the feet. That is the most common type. The best prognosis is for lentigo maligna melanoma. See, these are all one-liners. Don't try to even understand what they all mean. Most common world over, superficial spreading. India, acral lentiginous. Best prognosis, lentigo maligna melanoma. And what is the grading that you use to decide the prognosis? The prognosis is decided by a grading which is called as the Breslau thickness. It has to be less than 0.75 millimeter for it to be a good prognosis. Okay, so what is the grading? Breslau thickness. The critical Breslau thickness is 0.75 millimeter. These are all the points that you need to remember about malignant melanoma. And then the ABCDE of the lesion. I've put the image of BCC also. See, this is how a BCC is shown. A very important image-based question again. It is the most common skin malignancy. Happens due to sun exposure. Most common site is on the face because face is the most unexposed. Classically presents as a pearly, it means a shiny, skin colored plaque which has beautiful rolled up borders like you can see in the image here. Can you see these rolled up borders like this? Then it has telangiectasias, which are dilated capillaries, and it can have an erosion in the center, which can bleed. BCC is a chronic, slow-growing tumor which does not metastasize. So this is one malignancy which does not metastasize. It is, although locally aggressive, means it can eat up, invade the tissues surrounding it, but it will not spread to the entire body, which makes it a good prognosis malignancy. Then there is a type of BCC which I told you in the beginning of this video also, which is called as the rodent ulcer. This is an ulcerative type of BCC which has undermined margins. You get this question quite frequently, that is the rodent ulcer. So all these points about BCC are clear. When you look at the image, see the difference from the melanoma image in the question per se. This is the skin color lesion with rolled up borders. Then there is also an image of the marginal ulcer, which is again a very often asked question. This is a SCC which develops in a long standing burn scar. So this is a squamous cell carcinoma which develops in a burn scar. Looking at the image, see the surrounding area. Surrounding area is an atrophic scar which is suggestive of a burn that has healed. In the center, there is an ulcer with hypertrophic granulation. So this ulcer with hypertrophic granulation developing in a scar, very classical marginal ulcer. Question number 12. A patient suffering from ulcerative colitis presents with an ulcer on the anterior leg as shown in the image. Okay, so the history tells us that a patient is suffering from IBD, that is inflammatory bowel disease, could be either ulcerative colitis or Crohn's disease. Whenever there is a question which is associated with a skin association with an inflammatory bowel disease, whenever there is a skin association with inflammatory bowel disease, it can be one of these two neutrophilic dermatoses, either Sweets syndrome or pyoderma gangrenosum. So an inflammatory bowel disease, the question might even say that the patient has a long history of bloody stools. That also means either ulcerative colitis or Crohn's disease. For Sweet syndrome, the question will say red, painful plaques as shown in the image here. So for Sweet syndrome, the question will say red, painful plaques. For pyoderma gangrenosum, it will say a painful ulcer with undermined edges and violaceous margins, which are also visible in the image that was given in the exam. So look at the edges here. These are undermined edges with a very nice violaceous hue, exquisitely painful ulcer associated with inflammatory bowel disease. The treatment of choice for both of these neutrophilic dermatoses is steroids. That is also a question that you should know. Treatment of choice for neutrophilic dermatosis is steroids. Either it is Sweets or pyoderma gangrenosum, both will be treated with steroids. Sweets will present as red painful plaques. Pyoderma gangrenosum will present as a painful ulcer. Now coming back to our question here, there is an inflammatory bowel disease associated with an ulcer. Even without looking at the image, I can tell you the diagnosis, that is pyoderma gangrenosum. When you look at the image, all classical features, a violaceous margin and undermined edge is visible. What about the other options? Venous ulcer will not generally be given as an association with ulcerative colitis. Tubercular ulcer can have undermined edges. It can have bluish margins which you may not be able to differentiate on an image which is given in the exam paper. But the hint here is ulcerative colitis, which actually takes you towards pyoderma gangrenosum. Chancroid is an STD. It will be present in the genital area. Again, it will not be present on the leg. I have images of chancroid in venous ulcer. See, a chancroidal ulcer, as I told you, will be present on the genitalia. It will also be painful. It will also have undermined edges and necrotic slough on the surface associated with painful inguinal lymph nodes, which is called as bubo. Causative organism is a bacteria, that is Haemophilus ducreyi. Venous ulcers will be classically present on the leg, but on the medial side of the leg. Very importantly, they will be present on the medial side, just above the medial malleolus. The surrounding skin will be black. So surrounding skin will be dark, atrophic. And the ulcer will have irregular margins with a very dirty looking surface. So when it is present on the leg, it will be present on the medial side above the medial malleolus, and the surrounding area will be dark and atrophic. Again, very different from the image of pyoderma gangrenosum that you see here on the anterior leg. The question is classically telling you anterior leg. You know, it is taking you away from venous ulcer. Even if you don't spot the hint of inflammatory bowel disease, spot the hint of the anterior leg. And venous ulcer is not that painful also. Coming to the last question, which is patient presents with a history of severe sunburn after a few minutes in the sun, freckles and dry skin. So the question is telling us severe sunburn after a few minutes in the sun, which means that this patient has photosensitivity plus freckles plus dry skin. Even if I don't know the answer, I just know how to interpret the names of the genodermatosis, I'll be able to come to the answer. Melanocytic nevus? No, it will just be a black lesion. It will not have all these features. Warts? Not at all. To choose between Bloom syndrome and xeroderma pigmentosum, see, both of these have photosensitivity, but freckles and dry skin are hidden in the name of this disease. See, zero means dry. Pigmentosum means freckles and other pigmentary changes. So, the name of the disease is telling us the clinical features. The answer to question number 13 is xeroderma pigmentosum. Look at the image here. The skin is dry. It has so many freckles. There is corneal involvement because of photophobia. Then there may be different skin ulcers because of the photosensitivity. So the answer to this is the xeroderma pigmentosum. Inheritance, very importantly, autosomal recessive. Defect, very important question. NER defect, which is nucleotide excision repair defect. That is actually a DNA repair. Generally seen in consanguineous marriages, children will have a lot of photosensitivity, pigmentary changes on the skin, dry skin, and the photosensitivity will also be there in the cornea. So there will be photophobia, red cornea, there may be corneal ulcers, and due to the damage to the DNA that happens over time, these patients are very, very prone to developing all types of skin cancers, which includes BCC, SCC, and the melanomas. So all types of skin cancers can develop in patients of xeroderma pigmentosum. Clear? So with this, we end the discussion. All the best for your upcoming exam. Study well, study hard, but always with a smile on your face. Don't take stress, just do your job and you will score well in the exam. Thank you.